Good evening, everyone. These are my disclosures. And before I start, I would like to highlight that the greatest threat to people with HIV is not the suboptimal working COVID vaccine, but the complete lack of any vaccine. Despite being 2 years further, there remains a lack of equity of the rollout of these vaccines, which foremost affects the settings where HIV is most prevalent. In this talk, I will first briefly cover the impact of COVID in people with HIV and discuss the various COVID vaccine platforms with some effectiveness data. Then I will cover the vaccine immunogenicity in people with HIV, both responses after primary, booster, and additional vaccinations, and I will end by saying something on the relevance of hybrid immunity and some conclusions. People with HIV are at an increased risk of contracting COVID, and this meta-analysis of over 20 million individuals found a 24% increased risk in those with HIV compared to those without to contract COVID, although heterogeneity was high and differences per region in the world were also observed. When pooling the large cohort studies on clinical outcomes that have been conducted in people with HIV, an approximately 30 to 40% increased risk due to of mortality due to COVID is observed in people with HIV. And apart from age and number of comorbidities, the CD4 T cell count is a prominent HIV-related risk factor for this, as is also shown in this larger cohort from Spain. This risk can be significantly decreased by the use of vaccines, and the European Medicine Association, or EMA, has approved 7 vaccine platforms. On this slide, you can see the mRNA vaccines, where the primary vaccination cycle includes 2 doses 21 to 28 days apart. And after initial approval, boosters have been developed that include adapted strains in so-called bivalent vaccines, and the safety of the use of all these vaccines has also been demonstrated in people under the age of 18. The other 5 vaccine platforms include 2 vector vaccines, 2 protein-based vaccines, and 1 inactivated vaccine. All but 1 are based on the ancestral strain and can be used for primary vaccination, but none of these platforms are approved for vaccinating children below the age of 12. In the United States, 3 vaccine platforms have been approved, and there are other vaccines also in other parts of the world that I will not cover here. The registration studies on the vaccines are of course important, but the true value is defined when vaccines are used in the real world. The protective effect was confirmed across all age groups that received a primary vaccine cycle, as shown in these surveillance data from the United States Center for Disease Control, which covered 70% of the country's population. The mortality incidence is shown on the y-axis, and the calendar time of a positive specimen is shown on the x-axis. And as you can see, the risk of dying was consistently higher in those unvaccinated, especially for those 65 years and older, indicated by the blue, and the green lines, where up to a 9-fold risk reduction is observed in those vaccinated. Well, then looking at the boosters and zooming in on this period, they can have an added beneficial effect on mortality. So in this late Omicron period, in the selection of the included population, those who had received 2 boosters, shown here in red, had a 3 times lower risk of dying from COVID than those with the primary series only in blue. Surprisingly, I think that 1 booster did not seem to make much of a difference. But whether this is related to vaccine waning or the variants that are present, that's unclear, and it's supportive that other large real-world studies demonstrated similar results with different vaccine platforms. Globally, many deaths have been averted by these COVID-19 vaccines in all parts of the world, regardless of income, and it's now up to an estimated 20 million deaths averted. Vaccination is particularly important for people with immunocompromising conditions who are at increased risk of a severe COVID. We know that the vaccine efficacy is not so much affected by a higher age, but evidence suggests reduced protection from the vaccines for many immunocompromised persons. Recent studies in several countries actually found significantly lower vaccine effectiveness and antibody responses among immunocompromised adults compared to healthy individuals. It's also shown here in this figure from the CDC. It is particularly clear that organ transplant patients develop a lower antibody response after vaccination compared to people with cancer, on hemodialysis, or with other immunosuppressive therapies. In vaccine booster studies, therefore, the organ transplant patients have shown to respond very well to a third vaccine, and this is therefore now also recommended in many countries for immunocompromised populations. But of course, a relevant addition to this figure should be HIV. So now let's look a little bit further on the primary vaccination responses in people with HIV. A recent meta-analysis was conducted covering 34 studies with a high heterogeneity that looked at seroconversion rates after primary COVID vaccination by various platforms and regions of the world in people with and without HIV. Overall, as you can see in this table, seroconversion rate for people with HIV was high not only numerically, but non-significantly lower for people with HIV. The data additionally suggests that seroconversion rates in HIV might be lower in people from South America or by using inactivated vaccines, and importantly also in those with CD4 T cell counts below 500. But as you can see, these subgroups are relatively or increasingly small, so it's hard to draw any definitive conclusions on them. What's also relevant from this same meta-analysis are the adverse events, and they looked at it by these vaccines in people with HIV and fortunately found no safety signal. In fact, the risk of adverse event after a second dose might even be 36% lower compared to controls. However, also with this meta-analysis, several questions on the influence of a lower CD4 T cell count, antibody levels, and cellular data are not fully explained and warrant further evaluation, of course. The largest study to date was a nationwide cohort study in the Netherlands called COVI, and it was done on several aspects of importance of the primary vaccination of people with HIV by the 4 approved vaccine platforms in the Netherlands. Here included were 1,154 people with HIV, mostly virally suppressed, with approximately 1/4 with a CD4 count below 500, and 40% people with the age of 65 or older. They received either mRNA vaccines BNT126B2, mRNA N1273, or the vector vaccine Chetox-1S or AD26CoV2S, and most of them received mRNA vaccines. The primary analysis here was the anti-SARS-CoV-2 spike antibody levels 28 days after vaccination, and illustrated in this graph, across all vaccine platforms included, the mean serological vaccine response were lower compared to healthy controls, and 14% did not reach a predefined efficacy threshold of 300 BAL per milliliter. And these patients were identified as hyperresponders. HIV was also identified by multivariable analysis as an independent factor for hyperresponsiveness, and within people with HIV, a low CD4 T cell count had the largest influence, followed by a higher age and a detectable plasma viral load. A comparable study from Italy indicated similar findings of the primary vaccination across 4 subgroups that were categorized by CD4 count. People with CD4s below 500, shown here in red, and especially those below 200, which are the greens, had the lower antibody levels with less potent neutralization of ancestral viruses. The primary vaccination by the various vaccine platforms on people with HIV was safe and with a comparable frequency of adverse events in the first 7 days following first and second dose. Pain at the injection site and headaches were the most frequent complaints, and 1/4 of the population, or participants needed medication for these adverse events. Serious adverse events were fortunately very rare and always unrelated. Moving on to the T cell responses. Of course, these are important, and they could very well be compromised in people with HIV due to the nature of the infection. Here, exposing CD4 positive and CD8 positive T cells from a convenient sample of COVI, including both mRNA vaccinees in green and vector vaccinees here in blue, to peptide pools with both wild type and delta spike proteins, yielded interesting results in an essay that evaluated the presence and frequency of inducible activation markers on the cell surface in an essay called the AIM. First, what we can see are relevant proportion of both people with and without HIV remained without responses after vaccination. Second, the frequency of CD4 and CD8 T cells only responded significantly to wild-type spike but not to delta spike variants. Third, post-vaccination responses were comparable between people with and without HIV. An additional ELISpot assay showed good interferon gamma release in cells from people with HIV after exposing those to spike protein, which suggests that functionality of T cell responses might not correlate with AIM assay outcomes. The lower immune responses to primary vaccination seems to be of clinical relevance since more breakthrough infections are observed in HIV, especially in those with lower CD4 T cell counts, as shown here in blue in this cohort study from the United States. So let's talk a little bit about the value of additional vaccinations in people with HIV, especially in those with a risk for low responses. The COVID Boost 1 study was a nested study within COVID, and it evaluated the immunogenicity of an additional mRNA-1273 vaccine in a total of 66 patients that were hyper-responders after primary vaccination. Importantly, this study excluded people with intercurrent COVID-19 infection or high antibody levels at inclusion. After this additional vaccination, flow cytometric analysis demonstrated spike-specific B cells in all, as well as IgG class switches in most. And there was a good induction of activating, migrating in memory as specific IgG-positive B cell phenotypes. This resulted probably in the production of antibodies that were detectable in the serum, with seroconversion in all, and the graph here confirms also a high increases in antibodies against spike protein overall and actually in all platforms. And in the box, the red box indicates that there were only 2 individuals who remained hyperresponsive without any clear distinctive feature that categorized them. Also here, the T cell responses were measured by the AIM assay, but now cells were stained after exposure to ancestral and Omicron spike antigens. And similar to the primary vaccination, a significant proportion had no response. However, the frequency of ancestral and Omicron BA1 and specific CD4 T cells were relatively high at 68% and 75% respectively, without much increase after vaccination. S-specific activated CD8 positive T cells were infrequent and did not respond to vaccination, which contrasts the findings with these cells after primary vaccination. This low activation rate suggests impaired T cell responses after primary vaccination, and data from other groups indeed showed that people with HIV had inferior serological responses, which are called in this paper as low neutralizers, also had lower interferon gamma release upon stimulation with broad coverage spike peptide. Another group confirmed that interferon gamma release was indeed lower compared to healthy controls in people with HIV with lower CD4 T cell counts. So the question now really is how to continue with boosting in light of these data and the increasing hybrid immunity amongst people with HIV due to reinfections as well. Well, this study might help. This is evidence from a very elaborate study that suggests that people who received 3 mRNA vaccines and had a prior vaccination, either with the alpha strain shown here in green, or 2 prior infections, including 1 non-Omicron infection shown in pink, had decreased antibody levels against Omicron. And this contrasts with those with only an Omicron breakthrough infection that are shown in black, who actually had increased antibodies against Omicron. And the authors of this paper postulate that this is a phenomenon that might indicate immune imprinting and might result in hybrid immune damping due to a prior non-Omicron infection in those vaccinated. So one would maybe expect that immune imprinting would result in increased mortality, but epidemiological data do not provide evidence for this. This recent case control study from Qatar found that in those with a prior infection and who received 3 doses of the vaccines had the highest protection against symptomatic and severe COVID caused by the BA2 sublineage, and better even than those without prior infection. Omicron is rapidly evolving, and the hope is now that bivalent boosters containing Omicron-adapted spike antigens can help. Well, the data from this study indicates that low neutralization by bivalent induced antibodies is observed of major Omicron sublineages from the India and European continents. But again, here, breakthrough infection by an Omicron variant significantly helped covering these lineages as well. Another way to boost immune responses might be mixing and matching vaccines for heterologous vaccination, as shown here, where an mRNA boost of vector-vaccinated individuals yielded higher serological and cellular responses than using the same vector vaccine as a boost. So importantly, I think, with all the data I've shown you in the past few slides, is that these data on immune imprinting, protective effect of breakthrough infection, and immunogenicity of bivalent vaccination are not yet available for the population with HIV. So to conclude, where does this leave us with regard to COVID vaccination in people with HIV? First, vaccination has saved millions of lives, and this is especially important for people with HIV who are at an increased risk of dying and of vaccine non-response. Second, the COVID vaccines were less immunogenic in people with HIV. It was predictable by CD4 T cell count, and a third vaccine is effective for at least the serological responses. I have to say I'm less certain about the T cell responses, and that needs additional studies. The added value of hybrid immunity, durability of responses, clinical outcomes, and correlates of protection, especially from severe COVID caused by variants of concern, remains to be studied in HIV. Pooling the available data, I think that the best vaccination strategy in people with HIV should include standard third vaccination and boosting of immunocompromised people with HIV. I thank you very much for your attention. You can reach me by these contact information, and I'm happy to take any questions.